Hi, my name is Holly Neighbors, and I'm a student at Jefferson College of Health Sciences in the PTA program. And today I'm going to be discussing with you a patient that has been diagnosed with Guillain-Barré syndrome. To start off, we're going to talk about the patient's history. And this patient is a 30-year-old female. She has no significant medical history prior to this diagnosis. She is employed as a sales representative for a computer storage firm and was training for a marathon during the time her symptoms started to begin. 2 weeks later, while on vacation, patient had an initial onset of severe myalgias and arthralgias in her legs and unexplained fatigue. Patient then went to the emergency department and had many tests done to find out the cause of her illness. The patient was then diagnosed with Guillain-Barré syndrome. She could not walk on her heels and toes, very fatigued, and experienced weight loss. Immediately, she was admitted to the hospital for treatment. She had a rapid decline in function and was placed on a ventilator for 3 days due to respiratory muscle weakness. After 10 days of treatment, her mobility improved and her condition was stabilized, so she was discharged to an acute rehabilitation facility. She was still needing assistance with mobility, ADLs, and transfers. During her examination, observation revealed she required supervision with supine to sit because she was using her abdominals to be able to sit up. Manual muscle tests revealed significant weakness with extremities, more so than the trunk. Evaluation and diagnosis revealed that due to severe upper and lower extremity weakness, patient is unable to participate at work and recreational activities. Needs assistance with mobility, ADLs, and transfers, and patient is still unable to walk. Patient had no cognitive impairments. She has out-of-town family support. She is knowledgeable about her illness, and she was motivated. Patient's goals were to return to living independently and return running. The limitation and activity I chose to focus on is bed mobility, because if the patient is unable to reposition herself independently, then she is at risk for contractures and skin breakdown, and this could potentially lead to a longer recovery and more impairment. Bed mobility will increase her independence with transfers, help her to gain strength in upper and lower body, and allow her to progress to more difficult activities such as ambulating. Upper extremity muscle weakness and lower extremity muscle weakness are the impairments in the body function structure that I will be addressing. I chose upper extremity weakness over other impairments because it is important to have upper body strength for all ADLs performed throughout the day and to be mobile. I chose lower extremity weakness because it is also important to have lower body strength for ambulation, ADLs, and bed mobility. These two impairments limit this patient from being able to be independent in everyday life. I will address upper extremity muscle weakness while the patient is positioned in supine. Patient will flex trunk approximately 10 degrees by using her abdominals, and a wedge will be placed underneath the patient to maintain that position. While she is in this position, I will facilitate her biceps muscle with muscle tapping bilaterally to position her into supine on elbows. The wedge will be taken out from underneath patient, and she will begin bilateral elbow taps with weight shifting to initiate weight bearing through the upper extremity. This will help facilitate stabilizing shoulder muscles due to joint approximation through the shoulder. Patient will perform 8 elbow taps on each side with rest breaks if needed due to fatigue. I will address lower extremity weakness while the patient is in supine. I will first facilitate the hamstrings to flex the knee to get the patient into hook-lying position. I will place a wedge underneath the patient's feet to prevent the patient's legs slipping into extension due to weakness. I will then facilitate the patient's hip extensors with manual contacts by using light touch so that she is able to bear weight through her lower extremity and she will be able to bridge. The patient will perform 10 bridges with rest breaks if needed due to fatigue. After having the patient weight bear through her upper and lower extremities, I will put both tasks together to initiate scooting and with rhythmic initiation. Patient will perform 3 medial lateral scoots to each side with passive range of motion and 3 medial lateral scoots with active range of motion. This will conclude the interventions for this patient today.